Good morning, everyone. We will get things started up here this morning. Today is January 23rd. We are the Health and Human Services Finance and Policy Committee. Welcome to our committee this morning, and we are going to have a couple different reports brought to us today, and I think we'll start off right away with the agency update and overview. This will be the Minnesota Department of Human Services, and if our two presenters would like to come forward, and I know they've got a number of slides to share with us, and we'll just start it off. So I think Ms. Bailey is good. Are you going to lead us off this morning? So absolutely. Welcome to the committee. Please identify yourself for the record and move forward. Thank you.
Thank you, Chair Utke and Chair Wickland and members of the committee. My name is Elise Bailey. I'm the Budget Director at the Department of Human Services, and I'm here with Mr. Reese as well, and we're going to give an overview of our budget at DHS along with kind of a 101 on Medicaid. So I will get my computer set up here. And it's not popping up. Could I have help? Okay.
You're doing an extended screen instead of a
Okay.
duplicated screen.
Yeah, so we have new settings here.
Oh, there, is that it?
Yep. Then it was on Adobe.
Yep. Perfect. Thank you so much. All right, I'll just jump right in. Thank you. So over the last year since we've last met with this committee, DHS has been doing a lot of work on what our new agency looks like. As you may remember in the 2023 session, you all authorized different agencies that DHS used to include, programs around children and families, and programs that run our direct care and treatment program. In the 2023 session, those two functions split into their own agency. And so a lot of the work we've been doing over the last year has been around splitting those functions off and redefining what DHS is going forward. Part of that is what our vision and mission is as an agency. And so on the screen you can see that our new identity is taking shape, and this is what our new mission and vision is. I want to point out that the vision is kind of fundamentally different than what it was in the past. Previously, our vision was something around meeting folks' basic needs. And as we kind of look to the future and what our role is in state government, what our role is in supporting Minnesotans across the state, we want to thrive to do even better than that, better than just kind of the baseline basic needs. So you see our vision is really about helping people thrive rather than just meeting their basic needs, and helping them thrive in a community with no disparities. So that was important to our agency as we move forward. So this slide kind of goes over what it really means with the split. Prior to the split, DHS had a budget of about $26 billion. We had over 7,000 employees. And this is just kind of a snapshot of the funds that moved in the first year, I believe. DHS 2.0, our new agency, we have a budget of around $23 billion still after the split, but we have significantly less employees, so just over 2,000 employees. DCYF, now this is the budget that moved from DHS, so it's not their entire budget. I know they're gonna give a presentation later today, but we sent around $2.5 billion to DCYF in all funds, and about 500 employees. And then DCT, you know, that was a smaller portion of our budget of about $0.7 billion. but the bulk of our employees as they're doing direct care to folks needing support. So DHS also reorganized ourselves now that we are primarily a Medicaid agency, although we do have other funds, and I'll go over that today. But we have 5 policy administrations and then a central office function that's where our legal and financial operations and all of kind of the overhead minute systems lives. So our first administration is the Aging and Disability Services Administration. This was an existing administration before the split, but we've moved around some of the functions that existed in other areas. This is where our long-term care services lives. It's where we do nursing home and home and community-based services, as well as deaf and hard of hearing services and HIV supports. The Behavioral Health Administration, this is a new administration. Previously, it had other policy areas within it. So right now it's only focused on behavioral health. So they do policy around mental health, substance use, and gambling addiction. Healthcare, this is an existing administration. We had no changes here, but in the healthcare administration, and Mr. Reese will go over this in a little bit more detail, this is where we do the bulk of our Medicaid and Minnesota Care work on the basic healthcare plan. We have our provider enrollment area where we're enrolling providers. We have our federal relations where we're talking with CMS and other federal partners. The Homeless Housing and Support Services, this is a new administration that we had created after the 2023 session. And we've condensed all of the housing and homelessness supports that previously existed in multiple areas of the agency into this one administration so we can have a sole focus on this area. Here we are administering the housing stabilization benefit that's included within the Medicaid program. Housing support, which is another forecast program, general assistance, and Minnesota supplemental aid, along with a lot of the supports we have for people experiencing homelessness and our shelters across the state. Our Office of Inspector General, here is where we do program integrity work, background studies, licensing, and that kind of work. And then again, our central office. So diving into the budget, in fiscal year 26, we'll have about $23.8 billion in all funds at our agency. Our budget and programs impact about 1 out of every 4 people living in Minnesota. The bulk of the funds that we have are through the federal government, so about $12.6 billion, with the state general fund, $9.4 billion. We also have the Healthcare Access Fund funding our healthcare programs at $1.1 billion and other funds at $0.7 billion. You'll see the impact on the screen of people that we serve across the state. Almost half of kids across Minnesota are impacted by the programs we run. 29% of adults and parents, 17% of older adults, and 28% of people with disabilities are impacted by the programs in DHS. This slide just gives you a snapshot in fiscal year 24 of how many people received services in specific programs. So 1.3 million people received Medicaid, just shy over 100,000 Minnesota Care enrollees, 12,000 people receiving long-term care in nursing facilities through the Medicaid program, 89,000 people receiving long-term care in their homes and communities across the older adult and disability sphere. We also run the Behavioral Health Fund, where we are supporting folks through substance use and mental health supports, and in fiscal year 24, 34,000 people within that year received services through that fund. Within the Medicaid program, one of the eligibility categories I'll go over a little bit later is families with kids. That's our largest category in terms of number of people we serve, and over 800,000 people received MA in that bucket. General assistance, is a program that assists people, adults with disabilities in basic economic supports. Over 20,000 people received that in fiscal year 24. And then housing support, over 20,000 people. As I dive into the budget, I just want to kind of throw out some kind of stats across the nation on where Minnesota sits in comparison to other states. So America's Health Rankings in calendar year 2023 ranked Minnesota as the 5th state nationally for overall health. So while we have a lot of challenges to tackle together, it is good to kind of see where we sit compared to other states. We do sit 11th nationally in healthcare access, quality, and outcomes. Again, over 1.3 million people in Minnesota receive MA or Minnesota Care, including, almost half of all kids. We rank first nationally in services for older adults and people with disabilities, and 5th nationally in child well-being. So diving into the numbers, the slide up here just shows the whole enterprise as it relates to the general fund and where the Health and Human Services bucket lives within that. And the growth over time. So this includes more than just DHS. It's all of the Health and Human Services continuum across the agencies that fit into that bucket. But the growth you could see across the 4 years is pretty big. So in 24-25 biennium, we take up 29.7% of the general fund expenditures. And by 28-29, it will grow to 36.6%. If you look at all funds, we would represent 46% of the budget. As I mentioned, most of our funding comes from federal funds, and so when you include that, it's a bigger piece of the pie. This slide goes over that split between state funds and federal funds and how it's grown over time. And you'll see in all the slides that I go over from here on out, you'll see kind of the jump throughout COVID as we served more people and we received more federal funding. And then it kind of dipping after the federal health emergency ended. This slide goes over, slide 10, our budget over time. In the blue line, that is our all funds DHS budget. And then in the green line is what our historical spending would have been if DCT and the Department of Children, Youth, and Families were split at that time, just so you can kind of see that picture in a apples to apples comparison. So you'll see kind of key moments in our history in 2021. That's when kind of COVID hit and we started receiving a lot of federal funding related to responding to that crisis. At that time, we also were receiving an enhanced federal match. And as a condition of that match, we were instructed to make sure that folks continued eligibility for our healthcare programs. And so you'll see the growth in the MA program grow over time until the unwind begins. The unwind is what we call, the re-enrollment process after the federal health emergency. And that's where the enrollment and the spending is going down because fewer people are receiving services on that program. And then in fiscal year 26, that's when we consider the agency splits completed. For the split with DCYF, that started in this fiscal year. But there's some remaining spending and staff moving over beginning in fiscal year 26 as well. So that's when it will be complete. That's also when DCT will split officially from DHS. So that's where you'll see it in our budget. So looking into what we kind of spend our money on, about 89% of our budget is spent on MA. And we have other forecasted programs that I'll go over. That's about 6% of our budget. After the split, our grant programs take up around 3% of our budget. And our operations, so this is our staffing costs and our IT costs, that's about 2% of our budget. So diving into those slices of the pie, medical assistance, and Mr. Reese will go over it in more detail, but in this program, of course, we're providing preventative and primary health care to folks, behavioral health supports, including mental health and substance use services. We provide long-term care services and supports for people with disabilities and older adults, and nursing facility care for older adults, as well as facility care for people with developmental disabilities. Slide 13 goes over just a snapshot of what the MA program looks like from a budget perspective. So about, across the program, 54% of our funds are from federal funds and 46% are from the general fund or the healthcare access fund. And you'll see that growth and the changes over time of our budget, where by fiscal year 29, we're projected to spend almost $26 billion on this program in all funds. So the MA program is immense, and we provide, as I mentioned, quite a bit of different services to folks, and the cost of those services vary drastically depending on the level of care and services that people need. The long-term care facilities, waivers, and home care services under the MA program takes up a big chunk of that budget, so about $10 billion in fiscal year 26, or 46% of our expenditures will be spent in this bucket. We also slice the budget by eligibility categories under our basic healthcare services. So people with disabilities and older adults in the basic care, that will be about 21% of our expenditures, or $4.5 billion. Families with children will be about $4.3 billion, or 20% of the budget, and adults without children basic care will be about $3 billion, or 13% of our MA expenditures. So those were all funds, but it really does vary by eligibility category on how much federal funding we get for each category. So that slide 15 is a good depiction of how that varies. One thing I'll point out is generally we receive around 50% match from the feds for our programmatic spending. However, the MA adults without kids category, we get a 90% match. So any changes that the legislature makes that impacts that category really doesn't impact the general fund in a big way compared to the other areas, other populations that we serve. Slide 16 goes over the average monthly recipients of the program by those eligibility categories. So you'll see families with kids, we serve quite a bit more people than the other categories. And you'll see also that jump during the pandemic where we were serving more people, and then reductions in people re-enrolling as the unwinding project occurred. Slide 17, this just kind of gives a snapshot on comparing the number of people that we serve to the amount of annual expenditures. So of note here is with long-term care facilities, waivers, and home care, the spending is about $7.7 billion annually, but we serve around 100,000 average recipients per month, or per year. Oh, I went the wrong way, I think. And I know that long-term care isn't in the jurisdiction of this committee, but it's good to kind of be aware of the global landscape of MA. And so this slide goes over the number of people that we are serving in long-term care and the annual expenditures in that category. Long-term care has really changed over time drastically. And so this slide gives a good picture of where we're serving people and where they choose to receive supports and where we've come from in the past. So previously, prior to 2000, most people received long-term care in a facility, so in a nursing home or in an ICFDD. And over time, the state has really strived to meet people where they're at and where they choose to receive services. And most of the time, that is in their home and their communities. So you'll see the growth over time of people receiving waiver care and home care rather than in facilities or nursing homes. I put this slide up here because a big headline in our November forecast was around growth in the long-term care spending. And I just wanted to make this committee aware of where we're seeing those trends and why we're seeing growth in the program. So we're clearly serving more people generally, and more people are needing access to long-term care. The drivers of this are really generational shifts. Of course, the baby boomer is retiring and needing care over time, as well as the prevalence of disability increasing nationally. We are seeing younger people receive services in long-term care more than before, and older people accessing waiver service more than before. In the past, older people generally received services in facilities, and we're seeing a growth in both the disability waivers and the elderly waiver in receiving services in their own home. We're also seeing increases in racial diversity in the long-term care programs under the waiver services. Again, we're serving people in different ways, so people are accessing different services than they had in the past. They're receiving more services than they have in the past, and residential services continue to be a large cost driver in the waiver program. So these are services that people commonly refer to as group homes and customized living or assisted living. Those continue to be the largest cost driver in our waiver programs. We also are seeing increased payment rates, so both in nursing homes through value-based reimbursement, as well as in the waiver system, the disability waiver rate system. Mr. Chair, do you want me to pause if people have questions?
Yeah, thank
Okay.
you. And I will mention it. I had mentioned to some before we started, and I didn't reiterate when we had the whole group here, but because this is a long presentation, we would invite questions as we go, and we hit a natural break between slides or whatever. We would take those questions so we can kind of have that conversation with Ms. Bailey and Mr. Reese as we go. I do have one that I saw as you presented early on. We showed 1.3 million Medicaid recipients right now, or that we're serving. Prior to COVID, wasn't that number about 1.1? And I'm wondering, is the redetermination completed at this point, so this is a baseline, or is there still more work to do?
Mr. Chair, that is correct. The redetermination, the unwinding project is complete, and we are finding our enrollment at a higher level than what it was prior to the pandemic, and we anticipate that those trends moving forward.
Okay, thank you. Okay, Senator Bolden.
Thank you, Mr. Chair. I just have a quick question on slide 13. There's a pie chart that talks about the funding for medical assistance, and 54% comes from federal, and then 46% comes from general and the healthcare access fund. I'm wondering, of that 46% that is the general fund and the healthcare access fund, what's the distribution between those two? How much is general fund? How much is healthcare access fund?
Ms. Bailey?
Chair Atke, Senator Bolden, I can get you that number. I do know just off the top of my head, the healthcare access fund split is pretty small. So it's very, very, the majority of it is the general fund, but I can get that for the committee.
Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, thanks for the presentation. It is a little overwhelming, I guess, with the amount. But do you have we've had a lot of problems. You had a lot of money and serve a lot of people. Do you have some type of mechanism to deal with fraud? What's been documented, according to my information, from 2019 to 2025, there's Feeding Our Children and a number of others. We're up to according to this documentation that was sent out, $552,397,000 of fraud. And in fact, I did a radio program with one of the senators here on the committee, and who's quite familiar with this, and he indicated it's a lot closer to $1 billion now of fraud. Does the department utilize any type of technology analysis to identify fraud, such as earned value management system. A person closely associated with DHS sent me this email and says that a lot of things are put on automatic payment and they're not using a system to identify fraud when people are no longer eligible. Would you like to respond to that?
Ms. Bailey?
Chair Aki, Senator Gruenhagen, I can't respond to the numbers you threw out there, but I would say that we do use our data analytics around the claims that we have going through this system. I would say that the fraud schemes have become more sophisticated over time, and the department hasn't had the resources to develop, a sophisticated system up to this point. So we're utilizing the data that we do have and the resources that we do have to definitely look at fraud and definitely go out to those providers and look into the program integrity issues. I would point to the governor's budget where we are seeking resources to do just what you're saying. We want to utilize the current resources that all of us have in the country on AI, that, for instance, your bank texts you, hey, something odd happened. Is this a purchase that you made? We don't have that kind of dynamic system right now because we haven't had the resources and we haven't caught up to the current technology. So that is one thing, we would love to come back to this committee and talk more in depth about the potential for having something like an AI product where we could have a proactive approach to looking at, these claims kind of look weird over here, and have an automatic IT system that would do that.
Sure.
Senator Gruenhagen?
Oh, thank you, Mr. Chair. Yeah, thanks for that response. I just think members need to be aware that, we're dealing with billions of dollars, millions of people, and we don't have, in a technological age, a decent system to help identify fraud. And we're seeing that, what we know of is a lot, and sometimes you think it's the tip of the iceberg, okay? So I certainly encourage, in fact, I think that if you implemented fraud, it would be good to figure out what amount of money you would save, and you could probably offset the cost of the technology with the amount of savings that would be projected in savings of fraud, rather than more and more funding. Just my thought. One other question, Mr. Chair.
Go ahead, Senator Gruenhagen.
Yeah, we have, what system do you have in place if you have an illegal immigrant versus a citizen of the state of Minnesota? How do you sort that out? My understanding is, correct me if I'm wrong, federal funding is not, federal match is not tied to an illegal immigrant, where it is to a document, to a citizen of the state of Minnesota. Do you have a system for sorting that out, or how does that work?
Ms. Bailey, or it is Venus Health Insurance? Do we slide over to Mr. Reese, or you? Whoever wants to tackle that.
Chair Aki, Senator Gruenhagen, I think we could get back to the committee on our eligibility processes, but yes, the MA program has certain federal requirements in order to receive federal funding, and we comply with those federal requirements and make sure that our systems appropriately track folks' eligibility for the program.
One last comment.
Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, I would appreciate a response back on that. Because when we look at the growth, even though we split off some of these departments, when we look at the growth of our HHS budget, even according to this, soon we're going to be more than our educational budget in the state of Minnesota. So I don't know at what point, if we keep growing this exponentially, how the private sector is going to generate enough tax revenue to cover all this. In other words, I think we're on a path to bankrupt the private sector. And of course, when you keep doing that, become one of the highest tax states in the nation, you have a lot of businesses move out of the state and relocate or move some of their I just had one in my district that left, and they went to South Dakota. But so I think we really need to get a handle on this, and I think that especially with what we know the fraud is that's out there. Thank you, Mr. Chair.
Thank you. We'll take that as a comment, and we'll move over to Senator Abler.
Well, thank you, Mr. Chair, and I'm sorry I was late. I don't know, do you realize that Legions and VFWs pay property tax? So we're like, what? So we had a hearing about that. So maybe this is the year, Mr. Chair, which has nothing to do with this committee. And so while you're on this slide, I just have something that occurred to me. So there's expenditures we have, and then there's expenditures we would have had if people could have accessed the particular care that they're eligible for. And so, well, I'll just ask my question or just say my comment. And so many people want to find a nursing home bed and can't find one, and they're eligible, and so they go wherever they go, and they don't incur the cost of the nursing home bed. Many people want an elderly waiver bed. They're eligible and they're in dire need, but there's not one available for all kinds of reasons. We've been through those discussions before. Many people want to get a ride to the doctor with NEMT, and there's, I don't know the number, but it's tens of thousands of people can't get rides to those based on state policy. And group homes, and we'll discuss this more in the budget when actually I just thought of those, and those are all things that have been reduced in the governor's budget, and I'm not sure if you know what harm he's causing, but do you guys keep track of what people that are entitled to get care that need it, that we've all agreed on are eligible, who could not access because of inavailability of those services or finding providers to do it? Do you keep track of that at all?
Ms. Bailey?
Chair, Senator Abler, that's a great question. In some cases, we do know, for example, with disability waivers where we have, the county authorizing services, so we know how much they're authorizing, and we know how much we're paying, how many units are billed. In those cases, we know the gap between those two things, and sometimes it's a result of somebody not being able to find a provider or find services that meet their needs. Sometimes it's other things like, the units were over-authorized or something like that. So we can't really find out in the data the reasons why there's a gap. In other instances where there isn't a service authorization, for example, all of our basic care programs or even nursing facilities, we don't know the counterfactual, right? We don't know what doesn't show up in our system in claims. So that's a challenging question to ask or to answer, I guess, on if our system were absolutely perfect and we could always serve people at the level that they need it, what would it look like? Yeah, because you're right. We budget on a cash basis, so how much we're actually spending.
And Mr. Chair.
Senator Abler.
And so I'm not going to belabor it, but when the budget comes, I will belabor it. But I'm just going to give you a heads up on a question I'm going to ask. On each of those four areas, nursing homes, elderly waiver, NEMT, and group homes, I'm going to ask you for your modeling to support that your budget actually will keep those programs intact and provide the services they need. I'm particularly concerned about the NEMT where we've fought this before and it's going to collapse. The system's collapsing. These four areas are not serving the people that they're intended to serve. And I'm afraid the proposal that's been brought forward is going to do that more harmful. But I know in the department there's a lot of well-minded people or well-intended people. So I would like you to persuade me how it's all going to be fine if we do what the governor said. So that's my question ahead. But thank you very much. And I know the intention of everybody in this room who's connected to DHS, and they intend exactly what I'm saying, that people will get served. So thank you very much.
Thank you, and it looks like you've got some work ahead of you. At least you get a chance to, what you got to work on. But anyhow, we're going over to Senator Curran.
Thank you, Mr. Chair and Ms. Bailey. So to follow up on Senator Gruenhagen's questions around the area of fraud, in the history of Department of Human Services, I think there was a great discovery of fraud. We've seen this cycle before. And so 2011, I believe, the Office of the Inspector General was created to focus on and try and make sure we had all the tools necessary. We arrived, or some of us arrived, on 2017 when whistleblowers again break through or willing to go public with daycare fraud and the inability for those in the agency of the Office of the Inspector General are continually being redirected that they cannot pursue known fraud. And I think we're in that point again when we've seen all of the things that hit the headlines. of the interrelated feeding our future theft, which is then tied to a significant number of existing providers for DHF services. And it's the same thing again. In autism, autism services, you pick it, one of 6, 7 different categories: Medicaid, Medicaid equipment, transportation, right? Translation, autism services, adult daycare, child daycare, PCA services. And we're in the same boat. And this, we talk about well, we just hope we have more services or more tools. It's been the responsibility of the agency since its existence to manage these funds and to do great work, because it's a theft of services to a very needy population, and which we're all being constrained. So what will change? There's no IG currently occupying in the leadership position. It's still unknown why that position left. And I think we need some real answers. I know there's a variety of proposals. It's going to be a big topic this year. I think there's a House proposal, Democrat, Republican. The governor is thinking about doing more of the same. I just see it shuffling the chairs. I've been around long enough in state government. It's a shuffling the chairs. What are we going to do fundamentally different that will actually change it to where we can go and say, yep, we can prove we're getting great value, and whistleblowers stop calling all of us to talk about the actual things that are happening, and they have real concern about going public. We have very few that would go public, like a Scott Stillman. And so we battle that every day. What are you guys going to do differently besides add some more positions and hope it gets better? Because I don't think we have all the fundamental tools to make sure we have a truly independent Inspector General's office that is going to hold the agencies accountable, in addition to everybody that's in this process, to ensure that they're actually charged and pursued at every level. Because I think that's going to be which will move the needle, so we're not here in another decade having the same conversation. I don't see the shuffling, moving of the chairs. I want to see something really unique that's going to move the needle. How are you training your staff? What are you doing to bake in the accountability? And we're seeing it every day because we hear it from our people that need services, our counties where DHS isn't responsive. Those are the things that all accumulate into an ineffective system, redirecting or stealing services from our most needy. And I know you care about the most needy, but we would like to see some unique creativity, and we want to see an extraordinary amount of willingness from the agency and the governor to actually do something. And so with that, just give everybody an idea of how many FTEs are in the department and the Inspector General's office today, and how many new positions are being asked for to accomplish the job in which you've been assigned to since the beginning of time. So how many full-time FTEs do they have today?
Ms. Bailey, and I don't know how much of that falls within your wheelhouse, but I mean, if you can touch on some of those, but also I think part of this is the question is going back to other staff members too as we work on the overall challenge, but answer what you can.
Thanks, Chair Ecke, Senator Cran. I unfortunately don't have the exact FTE numbers for you, and I can certainly get that for you. And I would say at DHS, we are just as concerned as you are. I mean, we all work here because we want to make a difference, and we want to serve people who need supports. And when fraud occurs, that impacts the person, right? They're not receiving the services they need. It completely downgrades public trust and completely downgrades the program in its entirety. And so we are dedicated to working with you on solutions. I would say the governor's budget isn't reshuffling the chairs. We have a lot of innovative ideas in there, and it isn't just adding staff, which a portion of it is because our budget has grown to the extent it has as I went over, and the amount of FTEs we have is I think around 1% of the programmatic spending. So the growth in the program over time has not kept pace with the amount of staff that we need to oversee the program. But some of the innovative things in the governor's budget include giving us more legal authority to do payment withholds when there's suspected fraud. And right now we have some authority in law, but it isn't nearly enough. We have, as I mentioned earlier, an innovative proposal around systems and how could we leverage the private sector in adding to our system to do it better. And, you mentioned EIDBI, that is an unlicensed service right now. And so that limits our ability to go out and meet those centers on the forefront and check in with maltreatment reports and things like that. And so licensing those services is key to enhancing the program integrity for that program. And so I could go into a little bit even more detail on the governor's budget, but those are some of the key aspects, and we would love to come back and do a deep dive on this topic because, as I said, we are just as dedicated as you are to making sure that we secure the funds that we operate, and at the end of the day, make sure that people are actually served in the way that they need to be.
Thank you. Mr. Chair, quick follow-up.
Senator Coran, and if we'll shorten these up just a little bit, I want to get to Senator Liskey for a question, and we're going to get back to your slide presentation.
Okay.
And I hope you remember which slide you were on, because I flipped my pages around and I'm out of
think so.
Senator Coran.
Thank you, and thank you for your response. So I would hope that we move forward, because the challenges I know you're dedicated, but there doesn't appear to be consequences for when you fail. And across the board. So we've got people, Senator Abler talked about the needs are growing everywhere, and we continue to fail. And so theft is only a piece of it, but the rest is the efficiency and what are we doing to get out of the way of the actual private providers who actually provide the service. And so with that, Mr. Chair, I would request that I think we dedicate an entire hearing to the fraud, waste, and abuse conversation, and be open and creative during that conversation. Thank you.
Thank you. Senator Liskey.
Thank you, Mr. Chair. Mr. Chair, Ms. Bailey, I'm looking at slide number 19, and I heard a good story of a possible causation to the correlation that we're seeing, where you were talking about we're coming to the people want to be at home, we're offering more in-home services. I guess there's a possible other causation of this graph as well, is that we've reduced significantly the funding towards long-term care facilities. And in fact, 23 nursing homes since 2019 have been forced to close due to underfunding or not being able to be funded. So would that not imply that we could possibly also have a causation of, because there's no beds available, people are now needing to be in their homes? And then my concern is that in-home care can be more expensive at times than in facilities, nursing homes and such. So do we have an understanding of maybe that might be the cause? Have we looked into those situations and understood that?
Ms. Bailey?
Chair Atke, Senator Liskey, that certainly could be within the numbers. I would say generally, we do know that people are choosing to receive care in their home longer and as long as possible. I would say nursing facilities play a vital role in our long-term care system, and it is important that we have access to that level of care throughout the state. So yeah, I don't have causation in here, but we have seen beds decrease over time. The payment rates for nursing homes have increased over time, but they're spreading costs across fewer people that are seeking care in a nursing home. So there's a lot of dynamics there, but again, I would say that they do play a vital role. The department is definitely, wanting to ensure that we have a healthy nursing facility sector, and that they meet the needs of people, whether it be living in their own home or needing care in a nursing home. On costs, 9 times out of 10, or 9.9 times out of 10, nursing facility costs will exceed the cost to serve a person in their own home. It's pretty rare for it to be the other way around.
Mr. Chair.
Senator Liskey.
Thank you, Mr. Chair. I guess to follow up on that, the concern is, I'm hearing that they are important, which I agree with. In fact, I was heavy support of trying to find more funding in the last biennium for them. And unfortunately, it seems like we're talking about making more cuts towards long-term care, and that's concerning to me in a proposed budget where this is going to be, this is the issue, right? These people don't have the ability to cover that cost, and that's on the state to take care of them. And so I guess that's what I'm looking for, is hopefully we can reassess what that budget proposal looks like, because putting it on the backs of elderly patients is not a great idea.
Okay. Thank you. Ms. Bailey, if you want to get us back on track here with where we were at in the slideshow.
Thanks, Chair.
Thank you.
6% of DHS's budget is in other forecasted programs. So forecasted programs, again, are programs that are, the spending depends on the level of services and the number of people that need the service. So we have the Behavioral Health Fund that pays for mental health, residential, and outpatient substance use disorder services. Minnesota Care provides healthcare for low-income people who don't qualify for MA but still are low income. Our housing support program pays for housing and some services for individuals placed by the local agencies in a variety of residential settings, such as group homes. And then we also have the Minnesota Supplemental Aid Program, which is an economic assistance program that helps people who are on Social Security, and it's state-funded only, and then general assistance. This slide, I'll try to breeze through these more quickly since we're low on time probably, but within that non-MA forecasted programs category, about 0.7 billion is Minnesota Care, 0.2 billion Behavioral Health Fund, and then housing support, MSA, general assistance. Those are all funded, fully funded by the state. So the other two have some other federal expenditures in them. Slide 23 goes over the Minnesota Care program over time. Minnesota Care also had the impact of the COVID pandemic and enrollment increasing over that time, and then subsequently enrollment decreasing as we did the unwinding project. Minnesota Care is funded, it's our state's federal BHP program, and we get federal funding based on how much that person's federal tax credits would have been if they purchased health insurance on the exchange. In some years, that federal funding is significant, and the state funding, the state share of the program, is much smaller than what we receive through the federal BHP. So this slide kind of goes over what those slices are. We do also charge premiums on this program to the people and families receiving Minnesota Care, and you'll see during the pandemic, those premiums had been eliminated based on federal rules during that time, and they're now back and implemented back to what they were before.
Ms. Bailey?
Yes.
I think we had a question on the previous slide. Senator Abler?
Well, it's the same topic, so, and you can get back to me. I just, thinking about all this, so on the undocumented Minnesota Care, it kind of came up earlier. So I see there's quite a chunk of state-only Minnesota Care costs. Can you, I know it was $100 million, I don't know if it's a biennium or 1 year for that in the original thing. Can you get us the actual numbers about what we're spending now on the undocumented from the most latest forecast? So you don't have to answer it now, but just if you can get that to us, I think the committee's interested in that. So thank you.
Ms. Bailey, did you bring along a big, long notebook? Because you got a lot of to-dos.
I hope people are taking notes.
Thank you.
Cherokee Senator Abler, in the most recent forecast, we were holding those fiscal note assumptions because the program had not yet been implemented. We just implemented that part, I think, in January. And so we were holding what we had projected previously.
If you can just let me know what that is, so that'd be nice. Thanks.
Okay, thank you. Thank you. Proceed with your next slide.
All right, 3 other forecasted programs. This slide just kind of gives a snapshot on how many people we serve on those programs and the total amount of dollars.
Senator Gruenhagen, I think Ms. Bailey saw your wave too, so you
I was
can
waving at it, trying to be Minnesota nice.
go ahead with your question.
Yeah, just a quick question. The report for information technology projects for service delivery report is now almost 4 months late. The report shows the schedule of completion dates of these technology projects, the amount those projects cost, and the effectiveness of these projects. Is this report and other late reports almost completed to be reported to the legislature?
Ms.
Follow
Bailey?
me?
Chair, Case Senator Gruenhagen, I'll get back to you on what the status of that report is.
Thank you. Appreciate it.
You may continue.
Okay, slide 25 just goes over these programs and their growth over time. Okay, DHS also administers grant funds. That's about 3% of our budget. Slide 27 goes over the difference between what DHS was in fiscal year 24 when we had DCT and the Department of Children, Youth, and Family programs within DHS, and what it looks like now in our fiscal year 26 forecast. So previously, we administered about $2.5 billion, both state and federal funds in grants, and now it's down to $0.6 billion, so dramatically less amount of grant funding that we administer. Within that $0.6 billion, about $278 million, or 42% of that, is in behavioral health, so that's the largest bucket, followed by about 13% in aging and long-term care grants and nutrition and housing grants. Slide 28 just goes over that in a picture of how much our grants have decreased over time. We also get a lot of federal funds and grant funding. So starting in fiscal year 26, it's about half and half state funding versus federal funding in our grants. This last category is our operations. Operations includes all of the staff salaries, all of the IT costs to administer our DHS programs. That's about 3% of our budget in fiscal year 26. And this slide goes over what that amounts to as a percent of our programmatic spending. So looking just at compensation, so salaries of staff, that's about 1.1% as a percent of programmatic spending. Operating expenses includes our IT costs, and that's about 4.1% of total programmatic spending. Slide 31 goes over our FTEs and how that has changed or not changed along with the programmatic spending in our budget. So Senator Cran, I had mentioned this earlier in response to your question, but we've had a relatively stable amount of FTEs at DHS while our budget has grown dramatically. And so that's something to keep in mind when we talk about program integrity or other administrative resources, that our budget has grown, and that means the amount of claims that we're paying, that means the amount of providers we're working with, that means the amount of recipients on the program have grown over time, while DHS staff has maintained pretty stagnant numbers. And that ends my portion of the presentation. I've linked some resources for those of you who haven't had a chance to dig into some of the resources we have on our website, but you can look into our forecast in depth on that website. We also have our budget book that includes our change pages, but also each account that we have in our agency, and it goes over the budget and who we serve under those categories. And we have other reports and forecast information. So.
All righty. Thank you very much. We will move on to the health side of this report. And welcome to our committee, Jogo Reese. If you would please identify yourself for the record and proceed with your presentation.
Thank you, Mr. Chair and members. Giogo Hayes, Department of Human Services, Division Director in the Healthcare Administration. Given time, I'm going to breeze through a few of the slides, but if somebody has a question on something that I'm not giving some examples about, feel free to slow me down if you'd like. Just real briefly, work in the Healthcare Administration. This is an org chart of the Healthcare Administration where we do a lot of the functions in the Medicaid program. Ms. Bailey alluded to some of these earlier. I'm going to skip this slide for the purposes of time, but happy to answer questions if folks have those, and move to the next slide. You can see here, we at the department operate the Medicaid and Minnesota Care programs as well as some others, and about 1 in 5 individuals get their health insurance through one of these public insurance programs. And so the first thing I'm going to do is dive into a little bit about who are the folks on the program and kind of how they break down within the program. I always like to go over this chart. In fact, it's one of my favorite charts in the Medicaid program that tries to show you from a visual perspective how individuals end up on the program. You'll often hear that kids make up a large chunk of the individuals on the program, and you'll see in this chart a visual explanation of that, right? You can see at the very top, infants age 2 or children ages through 2 to 18 have a higher income standard in order to be on the program. About in the middle of the chart there, just showing the continuum of care for individuals who are parents, children 19 and 20, or adults under the age of 65. You can see somebody under the 133% of poverty could be eligible for Medicaid. As their income goes up, could be eligible for Minnesota Care as long as they stay under 200%. And then anybody who exceeds the income standards but is below 400 could potentially be eligible for advanced premium tax credits purchased through the exchange. And so this is just a nice visual that kind of explains a little bit why some eligibility categories are represented higher within the program. On the next slide, I usually walk through a couple examples, but I'll spare that for time. But just I like to use this illustration too, because if you're like me, you have no idea what 133% of poverty means, because nobody can track that stuff, and it also changes every year. But this is just a grid that gives you some examples, so you can kind of get a sense of what the income is for individuals served by the program, and it has the same income or eligibility categories that you saw on the previous slide. Moving a little bit to a little more detailed focus on the program. Here you're seeing two different charts. On the left side, you're seeing the regional breakdown of the state and the number of folks, or the percentage of folks within each region that are served by the Medicaid program. This is a chart that I like to show. It just shows, relatively speaking, a pretty even distribution of individuals served by Medicaid throughout the state. On the right side, you see kind of a county by county, and the lighter colors suggest that there's a smaller percentage of folks served by Medicaid, and then the darker green colors suggest a higher percentage of that particular county served by the Medicaid program. So again, kind of illustrates our neighbors and community members all over the state take advantage and use the medical assistance program. Ms. Bailey talked a lot about the financing around the program. This is talking about who, kind of understanding a little better who is in the program. And so these are numbers that talk about the individuals and kind of how they break out within the program. In the top there in blue, that's broken down by individuals. The green bar graphs is broken down by households. I'll focus on the blue here, but earlier Ms. Bailey mentioned around 1.25 million people currently served by the Medicaid program. And then on the bottom there, you can see that broken down by race and ethnicity. That helps us understand kind of who's on the program, make sure that we're doing our best to design the program in a way that meets the different needs of the populations throughout the state. On the next slide, you'll see a different visual representation of a similar concept, but this is in blue are the folks that are in the program, and then green, that same kind of population demographic in comparison to the state. And so you can see that there are some folks that are more reliant on the public programs than others, and so that's something that we try to focus on as we think about designing policies and outreach materials for folks in the program. This next chart is responsive a little bit to your question earlier, Chair Utke, about the enrollment in the program over time. So in blue, again, is the enrollment by individual, green is by household. So previous to 2020, you see just a little under 1.2 million, and with the end of the public health emergency after 2024, the end of 2024, there you see a little bit more, 1.25 million people. So you saw a peak there during COVID and the public health emergency where we had to keep people on the program for that period of time, and then kind of settling down at 1.25 million. So far, we've talked a little bit about the folks enrolled in the program and where they are on the state. This visual is a representation of where folks get care. And so the yellow is the counties that have less payment going to providers in that county, and the green is where there's a higher concentration of payment. Now, obviously, let's caveat that with, it's not that providers get paid differently in different counties, it just happens to be that that's where these providers happen to be located, right? We don't always have all providers, all specialists, all facilities in every single county in the state, so some of this is just a representation of where providers happen to have their business locations. But it does just give you a sense of throughout the state where some of the centers of care are and where there are some less areas of care. I'll just point out that this is on our public website for folks that are interested, and what you can notice from this on the public website is if you hover over any particular county, if you're interested, it'll tell you the number of providers receiving payment in that county, the average payment per provider within that county. On average, we pay about 25,000 providers throughout the state of Minnesota, over 60 million claims, and then the average depends on the type of facility and the type of services that those particular providers obviously provide. Moving to the next slide, what we're going to chat a little bit more about at this point is how members receive their care in the two different main purchasing models that we have. So you likely know that the vast majority of folks, around 80% of those served by the medical assistance and Minnesota Care programs, receive their health care through managed care organizations or county-based purchasers, and then about 21% receive their services through fee-for-service. So focusing on managed care here, like I mentioned, we contract with managed care organizations and county-based purchasers to deliver care. We pay them a monthly per member per month payment, referred to as a capitation payment, and we contract with those HMOs and CBPs on a county-by-county basis. So on this next slide here, what you'll see is a representation of the state county by county with the MCOs or CBPs that are serving in each of those counties. Not super surprising, you'll anticipate that the more populous counties generally have more options for members to choose from, and the slightly less populous counties have usually fewer options for folks to choose from. The other 20-ish% of the population receive their services through what we call the fee-for-service program. That largely means that the Department of Human Services is doing a lot of the functions that managed care organizations or county-based purchasers are doing. We mentioned earlier, we enroll providers, we pay claims, we set policies and procedures for how providers can submit claims and what policies and services are covered for the program. Around 300,000-ish people are served by the fee-for-service program. They largely fall into three buckets. One bucket is individuals who first enroll in Medicaid and are in transition to managed care. They might spend a month or two in fee-for-service as that transition happens. That's a pretty large bucket. The second large bucket is individuals who have other insurance, otherwise known as third-party liability. And so if somebody's on Medicare, for example, or if somebody has employer-sponsored insurance that we wrap around, they would be in the fee-for-service program as well. The last bucket are folks that only have fee-for-service, and that's their primary insurance coverage. A lot of times that's individuals with disabilities or individuals who are blind. Those folks make up about 100,000 people in the fee-for-service program and serve predominantly there. One thing to note is although most members get their services through managed care, there are some services that are carved out, if you will, of managed care and paid for by the department. There's a list of examples there that I'll skip for now, but largely those are for two reasons. Either one, it's a complicated payment methodology that doesn't get operationalized too efficiently in managed care, or second, it's related to a federal financial limitation that makes it challenging to operationalize in managed care, so we do it in the fee-for-service program. Speaking of federal financing, I wanted to take a slight deep dive, but a time considered to deep dive on federal financing. Ms. Bailey talked a lot about the federal financing at the aggregate level, and this is just a little bit more at the very granular level. You might, if you ever read any information about the Medicaid program, sometimes people call it a state-federal partnership. Sometimes people will tell you that it's financed 50% by the state, 50% by the federal government, and that's a slight oversimplification of the program. So as a couple examples today, the federal financial participation, or FFP, that we receive from the federal government for federal fiscal year 2025 is 51.16%, and so the state is picking up 48 point whatever the differential there is when the state is picking something up, and that's your typical match, and that's done on a claim-by-claim basis. So you come in for a X-ray. For a standard individual in the program, 51.18% of that claim in federal fiscal year 25 is paid by the feds at 51.16%. But what I wanted to illustrate here is there are numerous examples in which that is different. And so a couple examples here. Ms. Bailey alluded to the 90% match for adults without children. So that's one example. That's the first bullet there. But several other examples, for example, individual education programs or IEP services, that's actually done through what's called a certified public expenditure, where the school districts pay the state share, and then we draw down just the federal share. So the state share isn't coming out of this committee's budget, but rather out of the education space. There are services, one example being services delivered by an Indian health service, where the federal government picks up 100% of that claim, so there's no dollar from the state in those particular claims. Those are largely permanent FFP concepts, but there are some temporary FFP concepts. Ms. Bailey alluded to one of those, but a couple other examples. During COVID, the federal government picked up 100% of the cost for some vaccines and counseling. And then, for example, under federal law, there's an opportunity for states to pick up an optional benefit called health homes. Here in Minnesota, we do have one that's a behavioral health home, and any state that picks that up the first 8 quarters of delivering that particular benefit, we get an enhanced match. Those are all on the benefit side. We also get a federal match on our administrative side of the house as well. A couple examples there, systems funding, we obviously get a federal match, and there are some situations where we collect 75% rather than 50% for the federal government if we meet certain criteria. And another example is for state staff. For example, my salary is 50% covered by the state, 50% by the federal government, but we have some nurses, for example, on my staff who are licensed healthcare professionals, and so the federal government will pick up 75% of their salary, and we pick up the remaining 25%. And so this is just a slight overview of how the federal financial participation can vary by population, by service delivery, by location, all sorts of different features that add up to some of those aggregate numbers that Ms. Bailey showed you earlier. Rounding out to the last 2 points that I will make this morning for the committee. One, just a quick touch base on Minnesota Care. We've talked a lot about Medicaid, and as you've seen on numerous of these charts, that is our biggest health insurance program that we manage. But we do obviously manage the Minnesota Care program as well, around 100-ish thousand people. You saw a map similar to this in a previous slide, and it's the same concept here, but just for Minnesota Care. So again, you can sort of see that our communities have a relatively even distribution of individuals who might be served by the Minnesota Care program. And there are some different requirements for Minnesota Care. I'll skip some of these bullets, but move to the next slide and give you a couple examples of how the program is similar yet different in some ways as well. Minnesota Care, as was suggested earlier, does have cost sharing. The Medicaid program today, as of January 1, 2024, does not have any cost sharing. There are premiums in Minnesota Care, which individuals are obligated to pay before they receive service, so we have to receive the premium before their coverage may be effectuated or continue. And then some definitions that are a little bit different in Minnesota Care for a child and the age for a child and the benefits. I think the one point I'll make here so that we can wrap up in the interest of time is a point that I often make to my new staff as well, is the Minnesota Care program in statute is largely built off of what I like to call a Medicaid chassis. And so if you look in the Medicaid statutes, there's dozens and dozens of them. If you look at Minnesota Care statute, there's just about a handful of them. And for most situations, if you make a decision in Medicaid, unless it's expressly stated in statute, you have made that same decision for Minnesota Care. And so this in yellow here is just one tangible example of that. It says here basically that the benefits in Minnesota Care are the same as those in medical assistance, except for those ones listed there, special education, and a couple others. And so that's just something for everybody to note as you're working on legislation. If you're writing a bill that applies to 256B, it likely applies to 256L unless you've done some work in this chapter to modify that. Last slide here, real briefly, is just a couple of recent program changes that the committee might be interested in. We mentioned already the public health emergency ended, and so there was a lot of work in that space. One real quick success there was the ability to expand our use of ex parte renewal, or otherwise automatic renewals for individuals, and so people weren't falling off the program as often as they have been. A lot of times people fall off the program because they maybe missed a mailing or didn't submit a piece of documentation and then come right back on the program a month or two later, and so that was an improvement. There's some changes in January of 24 and January of 25 related to continuous eligibility for children. Just high level, I'll just say that those have been implemented and largely allow for kids to stay on the program, ensure they're getting the appropriate preventative screening and any health care that they need to stay healthy and be successful in school and whatnot. In January of 24, we expanded the adult dental benefit. You're probably aware we have some significant dental access issues within the public programs, and so that was something that providers and members shared with us as a hurdle, and so we were in partnership with you all able to extend that to be the regular benefit for adults. Definitely some investments in mental health with IEP services and in the community setting as well. I mentioned earlier the elimination of cost sharing and some additional investments in the program to address mental health rates and SUD rates as well. So with that, that brings us to the end. Happy to take questions if anybody has any, but in the interest of time,
Well, thank you very much. I do have one follow-up. Going back to your slide number 37, which showed the various income and asset guidelines. On the bottom, across all columns, it says no asset test. Didn't we go back to an asset test with the redetermination or the unwinding from COVID?
Mr. Chair, post the Affordable Care Act, the eligibility uses what's called a modified adjusted gross income for the vast majority of members, and that does not include an asset test. There are some categories, largely the individual with disabilities, that do have an asset test. But since 2014, most folks in the program don't have an asset test.
Okay, thank you. Okay, I saw Senator Abler first, then we'll go to Senator Mann. Okay, Senator Mann?
Thank you, Mr. Chair. With the new federal administration in place, you know, you noted that a lot of the funding comes from the federal government. I mean, we have now a federal administration who has said that they don't really believe in science or healthcare, asking the FDA and the CDC and the NIH to stop putting out health advisories, for example. Is there a plan in place, or are you concerned at all about federal funding and how that's going to impact the most vulnerable Minnesotans?
Mr. Reese or Ms. Bailey?
Cherokee, Senator Mann, that's a great question. At the department, we've established kind of a leadership team that includes our federal relations director, our Medicaid director, and our finance folks, our CFO, budget director, deputy CFO, and folks that would be doing data analytics around any given proposal. So at this point in time, we're kind of waiting for actual legislation or executive orders that would fundamentally modify the MA program. At this point, we've looked at what could potentially come out, and that includes things like lowering the FPG or the federal poverty guideline that would be expansive beyond MA. It would be many programs that rely on that standard for eligibility for programs. It could be something like lowering the federal match percentage. Right now, as my colleague mentioned, it's around 51% for Minnesota, and the state minimum is 50%, and it's based on the per capita income of your state versus the rest of the nation. So they could say instead of 50%, let's do 40%. That would have a drastic impact on the amount of funding that we get from the federal government to run this program. There are other items, of course, instituting work requirements that would, add to our enrollment procedures and fundamentally modify the number of people that are served. Per capita caps or block grants would drastically impact the state's financial situation as we have to administer the program. So we are trying to organize around how do we assess these different proposals on the federal level, and we'll be happy to work with you and provide you information as those come out.
Senator Mann, anything more? Okay. Senator Abler.
And, it's a worthy question to ask, and Senator Mann, it's something we all have to sort out whatever happens, and I don't know either. But so you provoked a question that wasn't what I was going to ask you before. So is the federal poverty guideline, is that set administratively? Where some agency says it goes up every year by inflation, but is that in the control of a bureaucrat?
Mr. Reese or Ms.
Cherokee,
Bailey?
Senator Abler, I'm not sure whether it's set in law or whether like a federal rule or administrative action. We can get that for you, though.
Well, thanks. And Mr. Chair, and then the corollary to that is this percentage that we get, is that statutory or just some kind of rule somewhere? The same question, I guess. So, a lot is yet to be seen. And so that is all prospective, and we don't know. And I didn't support the original block grant thing. I thought that didn't make any sense. I think flexibility in Minnesota's ability to do what we want. Oh, the feds require this. I'm like, why is that? Maybe a two-edged benefit somehow. But what I was going to ask you, I was very interested in this in slide 40, which talked about the ethnicity of people getting services. And I'm not surprised, but it was just really interesting to see that. And the African Americans disproportionately get that compared to any other group, as well as the Hispanics to a lesser extent, and then the tribes as well. So we've talked a lot about hospitals, and I'm just preparing you for the budget discussion. We've committed to service a huge percentage of these populations in our programs. And I have that sense of responsibility as well. It's a kind of a societal contract. We've decided we're going to do this. And yet, we have hospitals that are closing beds. We have hospitals that are full of people who can't move anywhere. And so these very populations that we agree should be served are the ones most at risk to not be served. If you look at people that are have more means, they can find a different hospital, they can get some other services. But these people that are have the privilege of having one of our cards are the ones most vulnerable. And so when you come back with the budget, I'm going to ask you again on the hospital side, how are you going to assure that this individual, some person living in wherever they live, needs to get to North Memorial, who's closing beds, et cetera? Where in the budget is there an assurance of that? Because I'm concerned that I don't see that. And Senator Mann, your concern is about what might happen. I'm concerned about what is happening. In today's editorial page, by a person who I have no idea who he is, some person named David Perry, he says, don't balance the state budget by targeting those who are most vulnerable. And not a good idea, if you didn't know my tone earlier. This committee unanimously would agree we do not want to balance a budget by targeting those who are the most vulnerable. But I encourage people to read this, and as we go forward, I sat through 2011, and it was hellish as we tried to find a way to do this very thing. And we agonized over it. It was carefully done, and many of you were around at that time. It was horrible. At the end of the day, we're short of money. If I were king, and clearly I'm not, I would balance half the deficit, and then in a thoughtful way, in a way that we can all pull together on, and spare these and even improve services by doing some things uniquely. So I am not questioning any of your motives. You all have a job to do. The governor's budget says this. I don't know if the governor even knows it's in his budget. But we're going to dissect it, and hopefully on a bipartisan basis, we're going to find a way to get Minnesota stable in their economies without doing it this way. So anyway, thank you very much. And I'm not yelling at you. I'm just expressing my deep concerns. I know too many people who are scared to death about what's happening today with this budget, with all the money that we have. And I don't know what happens when it changes. And I'll work with you, Senator Mann, to solve all the things we have to do. So anyway, thank you very much.
Thank you, Senator Abler. I'm going to go to Senator Gruenhagen, but I hope that it's a real short question because we do have another set of presenters that are going to come up to the table and talk to us about the Children, Youth, and Families Department. So if you can make it real quick. Thank you.
Thank you, Mr. Chair. Yeah, I have to represent my constituents here, and I'll just make a statement rather than ask a question. I go to these county commissioner meetings in the different counties, and then you have the HHS people who are in charge of the HHS. And they consistently, for the last several years, have said the same things. They have to meet with these people who are receiving services and fill out this form. Number one, the form is too big. It asks questions that aren't pertinent, and it's onerous, and they can't get to all the people. Give them some flexibility so that if they know someone is a paraplegic, they don't have to go back there every year and document that. They know their people, okay? So the counties need some flexibility in terms of implementing some of this paperwork that they're doing, where they spend more time filling out paperwork than they do helping the person, all right? So to the degree that you can modify that, I'd appreciate it. Okay, I'll leave it at that, okay? Thanks.
Thank you, Senator Gruenhagen. Your note takers this morning have been busy, so we appreciate all of them that are taking notes and going to have information for us as we proceed through this session. But Ms. Bailey and Mr. Reese, thank you for joining us this morning. Thank you for your presentation and the information you shared. And with that, we'll call up Ashley Reisenauer and Jennifer Summerfield to talk to us about the Department of Children, Youth, and Families. Welcome. You are going to share with us how the new department is up and running and what's all taken place, I guess. And Ms. Reisenauer, are you starting off with this, or Ms. Summerfield? Whoever's going to start, just as you all know the routine, please identify yourself for the record and proceed with your presentation.
Great. Thank you, Chair Uckey and Chair Wicklund, for having us this morning, members of the committee. I'm Jennifer Summerfield. I'm the Government Relations Director for the Department of Children, Youth, and Families. As Chair Uckey said, I am here with Ashley Reisenauer, and she'll introduce herself in a bit for her part of the presentation. For the part that I'm going to cover, I'll provide an overview on the creation of DCYF, the vision for DCYF, the programs that have been transferred, and then our leadership and organizational structure. And then at the end of the presentation, I'll come back today to talk about some challenges and opportunities that we have as a new agency. So on July 1, Minnesota launched a new state agency to create a sustainable public face for children's issues in state government with aligned outcomes and policy, improving the front door for services, easing access and navigation for families, and improving services overall. The agency vision, which is on this slide, is for a Minnesota where all children, youth, and families are valued, treated equitably, and thriving. This is our initial vision statement. The Children's Cabinet, in partnership with DCYF, have contracted with Wilder Research to complete a 5-year comprehensive strategic plan process that includes engagement in the coming weeks. And we will be capturing feedback to inform the development of a long-term strategic plan and a long-term agency mission and vision. The vision that our agency has aligns with the One Minnesota goal of making Minnesota the best state for children to grow up in, regardless of their race, ethnicity, religion, economic status, gender identity, sexual orientation, disability, and zip code. Moving on, our state depends on the success of all of Minnesota's children and youth and their families. DCYF was established to ensure that children are at the center of government, that their voices are heard, that there's a clear front door access to services for children and their families, and the programs that are available are easy to access, and that we are able to coordinate funding, programs, and outcomes for children and families. As we developed DCYF and put together an implementation plan, there was significant community engagement. And then as we finish our implementation process, we will continue to expand on those efforts to ensure that we're serving children and families in the best way possible. DCYF is going to use what we call a whole family systems lens to ensure our policy and program planning, both internally and externally, works with community and other state and local community-based agencies, is responsive to families' challenges and encompasses all aspects of their lives, including family well-being, family preservation, childcare, and economic stability. DCYF will partner closely with counties, tribes, early education providers, families, communities, and other partners to make sure we are meeting Minnesotans' needs. For your reference, this slide is our organizational chart for the agency that shares with you our executive leadership, our commissioner and our assistant commissioners. Our agency is structured with 4 administrations, and I'll delve into those in a little bit more deeply. This slide is just for your reference. It provides a list of the remaining executive team positions that we have. All have been filled at this time except for our Inspector General and our Deputy Commissioner positions. We're hiring an Inspector General over the next few weeks, and that position will be first placed at DHS for a knowledge transfer, and then will come to DCYF this summer in June. You may not know what our Chief Business Technology Officer is. That is an individual who works for Minute. His job is to collaborate with our leadership and make sure there are cross-functional teams that implement our IT solutions in a way that is modernized, hopefully, and supports sustainable growth of our agency. It's hard to run my notes and the slides at the same time, so apologies for being a little delayed. This slide shows the timeline for DCYF program transfers. The agency started on July 1st with a few employees, and since that time, we have come to be approximately 550. In July, Early Learning Services programs came over from MDE, along with our Children and Families programs from DHS. We added communications, human resources, our budget analysis division, government relations at that time as well. In October, we added central operating functions such as our grants and contracts and compliance units. We added human service performance management as well. This month, at the end of the month, from the Department of Health, Help Me Connect will transfer to the agency, along with some additional central office functions working on business integration. And then finally, in July, we will have our last large transfer, and that will be from the Department of Human Services, our portions of the Office of Inspector General, and then youth justice programs coming to us from the Department of Public Safety. Noted on here, there is the after-school community grant program that is currently at MDE. That program will, according to the enabling legislation for the agency, transfer to us when additional funding is provided. At this time, though, that program is funded through fiscal year 2027, and it will remain at DCYF to continue serving the community. This slide, I'll let you read through it on your own in the interest of time, but this simply provides a little more detail about the different programs and units that are at DCYF. I'm going to go through a few slides that talk about our different administrations and the work that they do. So our first administration is Child Safety and Permanency. This is led by Assistant Commissioner Rebecca St. George. She came to DCYF from serving as legal and policy counsel for the Mille Lacs Band of Ojibwe, and prior to that, she was also a city attorney for Duluth. This administration is responsible for overseeing the state's child protection system and many child welfare programs, including prevention, family preservation, foster care, and compliance with the Indian Child Welfare Act, or ICWA, and the Minnesota Indian Family Preservation Act, or MIFPA. The CSP team, the Child Safety and Permanency team, develops policies and practices intended to reduce overrepresentation of children in the child protection system due to poverty, political status, race, and disability status. They also manage a lot of grants that are sent out to counties, tribes, and community-based agencies to support better outcomes and ensure effective implementation of state and federal laws. In addition, the Child Safety and Permanency Administration partners with the University of Minnesota Twin Cities in the Child Welfare Training Academy that provides foundational and other training for our child welfare workforce. And along with that, there's a partnership with the Tribal Training and Certification Partnership at the University of Minnesota Duluth, which provides education and training to new and ongoing child welfare workers on ICWA and MIFPA, and then also how to engage with American Indian families and tribes during child welfare cases. The Early Childhood Administration is led by Assistant Commissioner Diane Halsey. Assistant Commissioner Halsey most recently served as the president and CEO of the Family Partnership. This administration oversees programs that support early childhood care and education with a focus on increasing access and supporting high-quality early education opportunities, as well as the early learning workforce. The goal of this administration is to support our youngest Minnesotans as they grow and develop. We've heard from families that they want early care and education programs that are accessible, affordable, and that will provide nurturing care to help their children develop, learn, and grow. We've also heard from early care and education programs, and they have told us they want resources that allow them to provide that type of high-quality care and education with a well-compensated, prepared, and supportive workforce. The next administration is our Economic Opportunity and Youth Services Administration. This administration is led by Assistant Commissioner Kate Weeks. She most recently served as the Executive Director of the Office of Justice Programs at the Department of Public Safety. This administration combines the Office of Economic Opportunity from DHS previously with youth justice programs from the Department of Public Safety. If you don't know what OEO does, the Office of Economic Opportunity, they administer a variety of anti-poverty programs through a network of community action agencies and nonprofit organizations. Their core areas include community action, food and nutrition, and the Family Assets for Independence in Minnesota, or FAME program. The youth justice programs transferring from DPS are intended to enhance the welfare of Minnesota's youth and broaden their opportunities for a future. The goal is to use science and research to ensure that young people are adjudicated fairly and given opportunities to learn and recover from youthful mistakes, finding ways to address barriers to success that they have once they've been involved with the youth justice system, support programs that prevent youth from entering the system in the first place, and involve families and communities as a critical component in supporting successful youth outcomes through restorative practices. The next administration is the Family Wellbeing Administration, led by Assistant Commissioner Dr. Shanine Moore. Dr. Moore comes to this role after working at the Department of Human Services, first as our Assistant Director of Child Support, and then as an Assistant Director, and then as the Director. And then she was also a Deputy Assistant Commissioner for the Children and Family Services Administration. This administration includes programs that are part of Minnesota's critical social safety net for children and families by providing food assistance, cash assistance, child support services, and employment services. And this is my last slide. You can read through it yourself, but I'll just note this shows the breadth of programs that we have and the number of people that we serve. You can see we serve 500,000 parents and children through our child support program. My understanding is that's approximately 200,000 parents and 300,000 children. And we serve a great number of families who are receiving SNAP, including, while not part of children and families directly, there are a lot of seniors who receive that as well, and individuals. So you can read through that, and then I'll pass it on to Ashley.
Thank you, Ms. Summerfield. I've got one question for you before we move on. As I just noticed on the last couple slides, is everything related to food shelves and their operations now going through this new department?
Chair Utke, yes, that is part of our Office of Economic Opportunity. So our food shelf program and food bank programs are both with the agency.
Okay, thank you.
Yep.
And we'll move on then to Ms. Reisenauer, and welcome to our committee, and please identify yourself and proceed.
Thanks, Chair. Okay, I'm Ashley Reisenauer. I'm the Chief Financial Officer for the Department of Children, Youth, and Families. We're going to do a brief budget overview of how we serve the folks that Ms. Summerfield talked about. So during 2025, programs and functions are continuing to transfer to DCYF from originating agencies. The transition year accounting structure is one tool that's given DCYF the flexibility to do that throughout the year. So with feedback from our partner agencies during this transition year, DCYF is continuing to use accounting structures in the originating agencies, the Department of Education, Department of Health, Department of Human Services. But even though the accounting structures, funding is remaining in those existing accounting structures, DCYF leadership has oversight over spending and priorities. We have interagency agreements and approval structures within the financial systems to manage the day-to-day operations and systems. New budgets will be set up within new DCYF accounting structures for July 1 of 2025. This next slide shows our DCYF's total expenditures as when we are fully transitioned. DCYF's total expenditures are projected to be about $3.7 billion per year. So while we are a new state agency, we're not a small state agency. We're the third largest state agency in terms of general fund budgets. But the largest source of our expenditures is actually federal funding, which makes up about $2.5 billion, or about 2/3 of our expenditures. The remaining $290 million comes from other funds, such as special revenue funds, et cetera. In addition to the expenditures that are shown in this graph, DCYF also oversees about $1 billion in technical and fiduciary funds, primarily through the child support program, which is about $640 million a year. So since those aren't state funds, they don't necessarily show up in fund balances, but they're an important component of the scope of DCYF's responsibility. The DCYF enabling legislation required that program resources and a proportional share of operating resources transfer from originating agencies to DCYF. So as a result, over 99.7% of DCYF's budget for programs, services, and administration actually transferred from other agencies to DCYF. So that includes not only the program funds, as well as the staff who support them, systems that implement our programs, but it also includes a proportion of central operations, things like finance, HR, other management services that transferred to DCYF. Sorry. You move faster than I do. In addition, the 2023 and 2024 legislatures appropriated funds for certain leadership positions that all agencies need, like a chief financial officer, and to address critical operating positions that DCYF needs to address to support some of the programs and services that we operate. So programs and services do make up over 90% of DCYF's expenditures. We have a large grant portfolio, about $2.4 billion, or just over 60% of our spending is in grant programs. I'll talk more about grant programs on the next slide, but the largest single program in grant spending is for food support provided through the SNAP program, which accounts for nearly half of that spending that you see. In addition, about $1.1 billion, or 30% of our expenditures, are for forecast programs that provide economic assistance, adoption and kinship assistance, child care support, and early child care programs. The remaining 7% is for program administration and operations. So right around half of that, or about 3.5% of our total spending, is for compensation costs. When all programs have transferred to DCYF, we'll have about 900 to 1,000 FTE. About 95% of those are positions that are transferring from originating agencies. In addition, our other administrative costs include things like systems, rents, and other operating needs that for supporting our programs. As I mentioned in the last slide, DCYF spends about $2.4 billion a year on grant programs. About 1/4 of this is state general fund, while federal funds make up the remaining 70%, and about 5% from other special revenue funds, et cetera. Food assistance provided through the SNAP program makes up about $1.2 billion, or about half of this funding, and is entirely federally funded. So that's a large driver of the spending you see on the slide. Other grant programs at DCYF provide and expand the availability of child care. They fund programs across the child welfare system. They provide economic assistance and poverty reduction, and support youth intervention and restorative practices. So this slide shows our total spending for each budget activity. And just in the interest of time, I wanted to give just a few examples of the types of grants that DCYF oversees. So an example is the Great Start Compensation Payment Program that supports over 6,000 child care providers. The Early Learning Scholarships that are provided to over 10,000 children between birth and kindergarten. Grants to county and tribal agencies to provide some of the core child welfare services, as well as prevention and family preservation work. We have economic assistance excuse me, for low-income families. Food shelves was mentioned, as well as the diaper distribution program. And then youth services such as the Youth Intervention Program, as well as the Restorative Practices Initiative. So forecast programs in which spending is projected based on enrollment and service costs account for about $1.1 billion in annual spending at DCYF. Just under 1/3 of that is state general fund, while about 68% is paid for by federal funding. Federal shares do differ among the programs, but the two programs, the early childhood and family education and the health and developmental screening, are entirely state funded. So the slide shows the 5 programs that we oversee, as well as the spending of total funds in state fiscal year 26. The MFIP program provides cash and food assistance to low-income families with children and serves about 77,000 people. MFIP child care assistance helps over 6,500 families who use MFIP to afford child care while they're engaged in work or education. Our North Star program serves over 19,000 children through foster care, adoption assistance, and kinship and relative custody assistance. The Early Childhood Family Education is a program for children birth through education, their parents, and parents who are expecting kids. It promotes learning development among young children with a focus on parent involvement, and serves approximately 17,000 children among 323 school districts. And then the health and developmental screening provides funding to public school districts, Head Start programs, and certain clinics to identify possible health or developmental concerns and link families to resources. So in fiscal year 2026, nearly 54,000 children are expected to receive a screening. That's our high-level overview of our budget, and I'll turn it back over to Ms. Sommerfeld.
Thank you very much, Ms. Sommerfeld.
Thanks, Ashley. Chair Utke, Chair Wickland, members, I'm going to briefly talk about just a few challenges and opportunities, which I'm looking at in kind of the same thing to close us out for today. I'll start the first challenge that we face is also an opportunity, and that is our social services information system, the child welfare functions that we're focused on right now. That system is 1980s and 1990s technology that was the agency started using in the 1990s. Over the years, many programs, additional data points were added to it. Last year I heard it described as a lovely snowball that rolled downhill and along the way picked up a lot of additional pieces that have since then slowed it down and made it difficult to use. The system was not built for the amount of work that it's currently doing and the type of work. It also lacks a lot of modern functions. In some places you can't do any copying and pasting, so child welfare workers at counties and tribes who use SSIS are required to enter and re-enter the same information over and over. And the system is unstable and tends to shut down for them. So our child welfare workers at counties are spending a lot of time doing data entry instead of working with children and families, which is bad for everybody in the system. It's also, for counties, I'll just note, an issue for hiring and maintaining staff. When people come in and have to work in a system where they're not working with children, that's not why they signed up to do child welfare work. This is an opportunity. We did receive funding from the legislature in 2023 to start planning for modernization of SSIS, among other IT programs when DCYF, part of DCYF was with DHS. We've carried that work through. We received $10 million last year that's set aside for us to start modernization when our plan is put together. And the governor's budget, I'm not going to get into it other than to say that there is a rededication of $10 million of IT funds in there for SSIS. So we do have a really big opportunity as a state to come together and improve this system and make it work for children and families and our child welfare workforce. We have some challenges and opportunities when it comes to affordable, high-quality care and early education. Minnesota families do need access to affordable, high-quality care and education opportunities, but right now there's a gap between what families can pay and what the true cost of high-quality care and education is. Our system operates in many cases on the low wages of early educators, and our work as an agency is to increase that access by making early care and education more affordable and available and ensuring that it is high quality through professional development and providing access to quality supports. We do, as a state, have an opportunity. As an agency, we are now aligning our early education programs and child care services to look holistically at that system and how to care for families in the best way possible. We know that Part C ECSE services are frequently delivered in childcare settings, or that many children who attend voluntary pre-K also attend preschool in childcare settings. These systems should work in a more seamless way, and we are hopefully going to be coordinating all that as a new agency to make sure that they do. We do have some opportunities right now for a social safety net. The Family Wellbeing Administration is in the process of implementing a number of historic reforms that were made for our Minnesota Family Investment Program, or MFIP. This is our program that provides cash assistance to families with children. We are putting in place 6-month budgeting, streamlining sanction policies, and sunsetting the diversionary work program, all of which were issues that the agency and the legislature worked on with counties as well, to make sure that we are better serving families, that the program is not overly burdened with paperwork, and that we are helping stabilize family incomes for a period of time so that they're able to move off of public assistance into a self-sufficient arrangement for their families. We also have a great opportunity by bringing in our youth justice programs. That gives us the opportunity to look at youth justice and youth services through not just a punishment lens, but also a human services lens, where we're focused on trying to make sure that children and families are not entering the system and that we are doing what we can to help our children and families thrive throughout their lives. Thank you.
Thank you. Members, we'll go to questions or comments. I have Senator Gruenhagen on the list.
Oh, thank you, Mr. Chair. Yeah, thanks for the presentation. We eliminated the Department of Children, Families, and Learning many years ago, but evidently it's back, right? So, I was just looking at programs transferred to you, and again, I have to represent my constituents. I see that you're going to be in charge of licensing functions for family child care centers, certified care, and child family foster settings, et cetera. In my area, we're social engineering the small, the state of Minnesota is social engineering the small daycare providers right out of business. I got people who had, I own an independent insurance agency. I have people that are customers of mine. They have been doing this for 20 years, and they're quitting. They can't take it anymore, okay? So, there's a lot of advantages to smaller daycare providers. Number one, just disease alone, rather than social engineering children into these large facilities, which seems to be the direction that we're going. Because when all those kids get in one place, if somebody's sick, it spreads to all the rest of them. In these smaller ones, you bring it down. Last session, I believe, on the Senate floor, I think it was Senator Steve Drazkowski brought up the new booklet for daycare centers. And it's grown to, if I remember right, I could be wrong, over 70 to 80 pages the new booklet is. And so your well-intention is actually creating crisis in the rural area. Parents can't find daycare to go, and then what they do find is very expensive. And I think the state government has a lot to do with that. And that is a travesty, okay? So to the degree that you could straighten that out and give some flexibility, especially to smaller, daycare providers, would be sincerely appreciated. Because what you're doing, or who's ever, and may not be you, but who's ever doing it, is creating a shortage and a crisis out in my area and most rural areas, okay? So I could say more, but I think you got the point, okay? Personally, I think I voted against creating this department. I would vote to get rid of it, to tell you the truth, and just assign it to other parts, but that's my personal opinion. The last thing, we're broke, okay? We got a 5.1 deficit coming up, you know that. And one of the things I was told, if we just froze inflationary increases to the budget, we would reduce that 5.1 billion from by between $2.5 and $3 billion, which would make it much more manageable. And I don't want to cut any services for people who are critically need those services. But I think if we froze inflation, it would go a long ways to putting us in a better financial situation. And we wouldn't have to cut services necessarily. And so anyway, just give some local flexibility to these child care small services. And let's not social engineer into the big ones. Okay, thank you.
Ms. Summerfield, if there's pieces in there you want to talk about, or just take it as a comment?
Yeah, we'll take that as a comment. I'll share that information. And just on the piece regarding licensing modernization work that's going on, we are, because that will be coming to us next year, just want to make sure you know we are coordinating with the Department of Human Services to make sure that when that transition happens, it's seamless and that we are aware of what's going on with the programs and able to step in that role. And I'll take the information you provided to heart.
Okay, one quick comment, Mr. Chair.
Senator Gruenhagen.
I think all of us need to understand that when you plant a new agency, it starts growing, okay? And just like Jack and the Beanstalk, all right? And the next thing you know, it needs billions and billions and billions, and in many cases, it creates more problems than it does solve, especially at the local level. Thank you.
Okay. We're going to Senator Abler.
Well, thank you, and we'll have some more child care discussions later. I'm not even going to go there. But anyways, so where are you guys housed?
Ms. Summerfield.
Thank you, Mr. Chair. Senator Abler. Right now, we are leasing space at the Lafayette Building that used to be, it is part of the DHS
Yeah.
building package. We were actually, Children and Family Services was there previously, so some of us have not moved offices. We remain in the same location. And then our MDE programs have moved over into the Lafayette building. We have 2 floors, and then we have DPS will do the same.
All right, so you're all going to be together at some point in a, all right,
Yep.
that's close enough for now.
Senator Abler.
And so just the last thing, the homework department, Mr. Chair. So I appreciate the time you spent with me, briefing me on this. It was very helpful, and I get my head around this being a whole new agency. I hadn't even captured that, so now I'm catching on, and you know, it's a worthy experiment, and I really hope it works. It's another model. Let's take a run at this one. You mentioned that you're going to be moving some of the restorative justice and so on programs there, and when you come back with your budget, I'm going to ask you about how doing less of that is going to help you accomplish the goal, because the governor's there again, thought there was just too much of that, and so we cut the budget by a third or so, effective July 1. And so you can explain to me how that even makes sense. Because we've talked about upstream and preventing, and so, and the grantees are going to be notified July 1. Oh, by the way, if we pass this, which I'm not sure we should, but you can persuade me why that's a good idea. So thank you, Mr. Chair.
Thank you.
Thank you. Any just that's another.
I will just take that to heart.
Okay,
Be
thank you.
prepared for next time.
Senator Cran.
Thank you, Mr. Chair. And Senator Abler held off on the additional child care comments. I'll make them. So my wife was an in-home hospice provider, was forced out because of crazy COVID policies. But she opened a daycare, so very enlightening. And so I've had great access to the people who consume in-home daycare services and what their desires are. We know the rules. We've kind of held off, I think, of the crazy proposal that came out last year. What we have and what we'd like to see, we've continued. I think we've achieved the results that the policies were set out to do. Punitively punish in-home daycares and reward centers. In one of my counties, I have Chisago and Iceni counties, so we have a need for 1,000 slots in daycare. And we don't have them in-home. We have only about 60 licensed daycares and that includes centers as well. But within the centers, we have about a little over 100 empty slots. And so I think it's really clear. It's not what they desire. There's 2 components, one cost and then the true desire of what they want. I ask every one of our parents, and I've been involved in a lot of the conversations around the states when the crazy rules were rolled out. And some desire to put all these crazy requirements in there, the number of toys, a curriculum, an education curriculum. Interestingly, most of our parents, I haven't heard a single parent yet say, I want an education curriculum at their in-home daycare. They literally just want somebody as close to mom or as close to grandma as they could get that lives in their community. They understand their job and what their role is from an education perspective, get many years to work on that. But the skill sets or the skills and the socialization and what they obtain in that in-home setting, that's what's desired. And so we need to get off of this crazy regulatory piece outside of safety and security and those things. And if you look at what was proposed, none of those kids currently live in those types of conditions in their own home. And so we have to be very practical about what somebody can do. I was very lucky. Our house was modeled. I have a spare floor in the house. I do all the work myself. And it still cost almost $30,000 to update everything from our facility or from our house. If you don't even have the base foundation, it can be really tough. And there's no way we could subsidize our way out of trying to grow that. And so my comments are made just to say that we want to be at the table and we want something practical to come out of it, because I think we're achieving the goals that were desired. And the desire should be to grow those in-homes in every way, shape, and form we can, because clearly they're not buying what we've done to the industry and as far as its capacity as it's been built out. And the policies drive that. So look forward to working, helping, but we want some real creative things to get rid of the punitive. Take those mandates that were there and make them suggestions, give education. Those things are all great. But to mandate them is going to just push more people that are currently in the system out. And so statewide, I think we need likely 5,000 in-home daycares today. I don't see anything where we're attempting to correct that problem, so we want to help you with it. So thank you.
Thank you.
Thank you. I've got one question. As we went through your executive team members back on slide 8, when it shows the Inspector General spot is vacant, is that the overall Inspector General, or do you have that within your agency too?
Chair Aki, yes, that will be within our own agency. So when we move over functions from DHS's Office of Inspector General, we will be getting licensing, and we will also be receiving our program integrity functions related to the programs that sit in DCYF. So we will have our own Inspector General that will be managing our Office of Inspector General in our agency.
Do you know the time frame on that, when you hope to or anticipate filling that spot?
Sure. My understanding is the goal is to hire in the next couple of months, and then that position will be working with DHS to have a knowledge transfer arrangement to make sure that that person, when we have our own OIG, is ready to hit the ground running. So I expect we'll have somebody on board very soon.
Super. Thank you. Members, any other comments, questions? If not, thank you very much for joining us this morning. We appreciate it.
Thank you.
And members, okay. All righty. Once again, thank everybody. And with that, we will stand adjourned.